Come on in, you guys. We got a brand new episode of Jimmy Rants in store for you here today. JimmyRants.com is the website. As always, you can engage live in the content, but you really need to go follow me. I'm over on Instagram at Livin' Low Carb Man, LivinLowCarbMan. Once you are there, engage live just like all these wonderful people coming in right now. Thank you guys for being here today on Jimmy Rants. We also simulcast over on my Facebook page. Thanks to all you guys for watching as well. And on YouTube Live. So thank you, all the formats that you guys watch Jimmy Rants on. Really appreciate your attendance here. We try to do a pretty good show for you. If you missed the live, they do keep them up on Instagram for 24 hours. So go check it out. After 24 hours, it does disappear. You'll need to go over to JimmyRants.com to see the past episodes, and then we also house a lot of them over on YouTube. Type in the keyword Jimmy Rants, you'll find the show. All right, guys, so I wanted to bring to you some pretty cool information that was published in a journal. There's so many messages put out there when it comes to health that people just automatically believe. And unfortunately, a lot of those beliefs are just that. They're just beliefs. They're not really predicated on anything. And unfortunately, a lot of the things that are said about health are said by medical doctors, and they literally have no science that supports a lot of things they say. And so one of the things that comes up, and it happened to me, is when you eat a low-carb, high-fat, ketogenic diet, almost invariably, your doctor is going to express concern about your high cholesterol. That happened to me when I went on the Atkins diet in 2004. I did the Atkins diet. I lost 180 pounds. And then I go see my doctor in January of 2005 after this 1 year spectacular change in my weight and my health. And the first thing he said back to me when I told him I did the Atkins diet is, "Oh, what's your cholesterol?" I was like, really? Like, that's the default position? Not good job on the weight loss, not wow, you look so healthy, not way to go, I wish I could get my other patients to be motivated like you. It was like, no, let's see what your cholesterol is. And I remember he ran it. And when I went back in for the follow-up visit, he was just like all grim and gray. Oh my God. Oh. So what's your problem? He's like, man, your cholesterol is horrible. Well, what's that mean? He's like, your total cholesterol is 247 and your LDL is 156. Oh, now remember, this is the same doctor that had put me on both Lipitor and Crestor, and it was the Atkins diet that got me off of taking those drugs. And he was all back crap crazy because my total and LDL cholesterol were high according to his standards. So then I remember I had started educating myself a bit about this. I remember asking him, well, what about the other numbers on the panel? What about that triglyceride number that was 43? Isn't that good? Oh yeah, that's good, but total and LDL are what matters the most. Yeah, but what about my HDL cholesterol? That's the good cholesterol. Everybody recognizes it's good. It was 72. Unbelievably good. Yeah, it's okay, but LDL and total cholesterol. And so he was this one-tracked mind of what my cholesterol panel was. Why do they even run the other numbers if they're just going to ignore triglycerides and HDL? So that's the battle a lot of us have faced. So you go to your doctor and you say, oh, I went on the keto diet, and then they raise a stink because your cholesterol may go higher. And so I'm positing a statement here today based on a case study that was published that higher cholesterol for a ketogenic dieter really is not a big deal. We've been made to believe it's a big deal, but at the end of the day, it's really not as big a deal as we think it is. Do you still worry about your cholesterol? Is that something that when you go to the doctor, obviously the doctor pays attention. And let me explain something to you. The reason your doctor makes a big deal about cholesterol is they have specific guidelines that they have to follow for their standard of care. Specific guidelines for cholesterol. So did you know that there are cholesterol guidelines? I did a whole Jimmy Rants about this last year, but it bears repeating early and often. They have guidelines that say if your total cholesterol is over 200 or your LDL-C cholesterol is over 100, that they must prescribe you a statin medication. That is in the guidelines for their standard of care. If they don't do that, then they don't get reimbursed by insurance. They get dinged on their file because blah, blah, blah. But if you, the patient, decline it, then they're off the hook. Or if you take the prescription for Lipitor or Crestor, but then they don't care what you do as long as you take the prescription. You can fill it or not fill it. That's your choice. But take it from them. The only thing you can't do that they just get really mad about is if you say, well, I'm just not going to take any medication, and you don't take their prescription. They can actually call you a non-compliant patient, ding your file, and they could fire you as a patient. Now, a lot of people, they don't understand the dynamics of all this. They just roll over and obey and take the pill. That's what a lot of people do. They just take the pill willy-nilly. Well, the doctor wouldn't put me on any kind of medication that would be harmful to me. And, oh, yes, I have high cholesterol, and thus it's a disease. It's not. But it's a disease, and you need to take a pill to bring it down, blah, 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 blah. And that's the way things have gone. Well, we now have a new case study, and it was published in the journal Frontiers in Medicine. And this was in April, which was last month. Looks like it was done in Russia, and they wanted to look at a ketogenic dieter and a standard lipid panel to see if it had any kind of connection between people that eat keto and then what happens to their cholesterol and whether it actually has any meaningful information in terms of your health. Because we've always been told, get your cholesterol lower. High cholesterol is an enemy in your health. You're going to get heart disease. You're going to get a heart attack. Isn't that what we've always believed? So now this researcher wanted to do a case study that said, I don't know if that's true or not. Let's take a closer look at this case study. So the case study is called A Standard Lipid Panel is Insufficient for the Care of a Patient on a High-Fat, Low-Carbohydrate Ketogenic Diet. So in the introduction, they say keto diets are high-fat, low-carb. They induce the liver to generate ketone bodies, particularly beta-hydroxybutyrate, which is a metabolic energy source and signaling molecule evolutionarily designed to efficiently fuel the brain and the body during times of carbohydrate scarcity. Although clinical studies implementing ketogenic diets have heretofore been difficult to conduct, more research is needed, but a body of data demonstrates that the ketogenic diet may be useful in the treatment of a wide range of chronic diseases, with their common pathology being inflammation. And you guys have heard me talk about that a lot. That's the reason you eat keto. Keto is not a weight loss diet. Keto is not any kind of magic pill for anything. Keto is probably, arguably, the most anti-inflammatory diet you could possibly eat. And we know that inflammation is at the heart of all chronic disease. If there's no inflammation, no disease can take place. And so making sure that you eat and live in such a way that reduces inflammation is the key. And so that's what they're underscoring here. One of the diseases is called ulcerative colitis, which is an inflammatory bowel disease. Ketogenic diets may help dampen the inflammation within the gastrointestinal tract, inhibiting the activity of NLRP3 inflammasome. It also promotes intestinal stem cell regeneration and gut healing. and it stimulates the release of bile acids that then help with intestinal immune system homeostasis. So that's the patient that this researcher is looking at in this case study has this particular disease. Because ketogenic diets are high in fat, the still prevalent lipid heart hypothesis assumes that high dietary fat intake will cause poor cholesterol profiles, which they say elevates your cardiovascular risk, and that it's medically responsible to follow the serum lipids of individuals when they eat a ketogenic diet. Have you been to see your doctor when you went keto? And when you tell them you're on a ketogenic diet, were they real concerned that you wanted that they wanted to make sure they watched your lipids to make sure they stayed in a healthy range? Yeah, I think a lot of us have. And it's amazing to me, this one-track mindedness when it comes to your health. Your health is more than what your total cholesterol is. Can we get that straight? Just as your health is more than what your weight is. But they want to put it on all these like singular numbers when most good doctors, especially functional medicine types of doctors, they look at the totality of the patient. And it's through looking at the totality of the patient and looking at the patient themselves that they come up with, okay, yes, you got things going on over here, but in the totality of looking at everything in a broad spectrum, you're pretty darn healthy. How rigorously we follow serum lipids matters. Standard lipid panels commonly ordered typically only report total cholesterol, HDL-C, LDL-C, and triglycerides. That's called a standard lipid panel. These are simple metrics, but then we use these simple metrics to make clinical recommendations. However, it is now very well established that lipoprotein particles display remarkable heterogeneity in form and function. So for example, larger LDL particles, the large fluffy LDL, remember I've told you about this test before, it's called an NMR lipoprofile test. There are some other ones that do it, but that tends to be kind of the go-to test for getting your particle size, your LDL particle size. So NMR lipoprofile test is what that's called. And the larger LDL particles are non-atherogenic, which means they don't cause heart disease. And different HDL particles secreted by the liver appear to display different atherogenic properties in association with various morphologies as well. Furthermore, other lipid parameters are highly relevant to cardiovascular risk. Listen to these, you guys. You might not have heard of these before, but these are critical, and you can measure all of these with blood tests as well. Oxidized LDL. So think about what oxidation does to like metal. When you think of oxidized metal, you look at rust. So the LDL can actually get rusty, and you need to know how many oxidized LDL particles you have. You can actually run that number specifically for oxidized LDL. Lipoprotein (a) is another one that is a key health marker that's looking at various particles that could be atherogenic or non-atherogenic depending on the situation and what the number is. So you want to know what those measures are. They're not reported typically by your doctor. Have you ever had an oxidized LDL? That's kind of an archaic one. Not many people run that one. But lipoprotein (a), so it's LP and then in parentheses A, little a, lowercase a, and if they're not running that, how do you know how your heart health is going? This standard lipid panel doesn't show you lipoprotein (a). The standard practice of ordering a simple total cholesterol, HDL-C, LDL-C, and triglycerides is likely rationalized by the assumption that there's enough commonality in the population for these to provide sufficient information to make a clinical recommendation. Think about those numbers. And with the knowledge of knowing, we have other technology like the NMR lipoprofile test, which can show you the size of the particles, LDL particles, the total number of particles. You can really get kind of the nitty gritty. Then things like oxidized LDL, then things like lipoprotein (a). Why would we not run them all? Like, I get it, doctors are kind of narrowly focused because they have 29 billion reasons to be narrowly focused on a standard lipid panel, 29 billion being the amount of money made annually by statin medications. And let's not pretend like doctors don't get a kickback from that. They do. Lavish vacations, you name it. And so that's why they only run a standard lipid panel. And it's why they don't really love it when people go on a ketogenic diet, because they think those changes in that standard lipid panel mean something. So what this researcher here, and again, if you joined us late, I'm going over a case study published in Frontiers in Medicine, came out last month from a researcher in Russia. And they want to see if a standard lipid panel really tells you anything when you're a keto dieter. And they're positing the theory here. They're sharing the information, looking at this case study I'm about to tell you about, that it doesn't really tell you enough information about how the patient's doing. This case study demonstrates that assumptions about cholesterol may not hold true, particularly for those who eat a high-fat, low-carbohydrate ketogenic diet. Okay, so let's take a look at this case study. The subject is 24 years old, white Caucasian male with biopsy-confirmed ulcerative colitis, which was diagnosed 3 years prior at age 21. He exhibits normal blood pressure, a healthy BMI, leads an active lifestyle, and has no history of any kind of relevant comorbidities, which could include things like diabetes, prediabetes, something like that. Some other condition, that's what comorbidities means. Nor does he have any confounding lifestyle patterns like smoking or alcohol abuse. From the time of diagnosis, his disease has been his chief medical complaint. Although his inflammatory bowel disease temporarily went into symptomatic remission using various oral medications, including prednisone, he began to experience repeated flares several months later after taking the meds. He was subsequently treated with mesalamine and prednisone enemas, so that's where they squirted up his butt. That's not fun. Both of which failed to induce remission for more than 3 months. A total of 3 colonoscopies, as well as measurements of fecal matter, revealed persistent rectosigmoid inflammation. So in other words, despite all of the best things that modern medicine could do, he was still in a very highly inflamed state. So all the medications in the world was not helping with this. And even a draconian step as putting an enema, which basically when you push this straight up the keister, that's supposed to put it directly into the gut, which would help deal with this. Unfortunately, it did not. The subject also experienced other inflammatory phenomenon during this time, had swollen joints, had rosacea, his HSCRP, which is that key inflammation marker you hear me talk about a lot, it was actually below 3.0 milligrams per liter, which is a really good, anything under 3.0 is pretty decent. But he still had inflammation that wasn't showing up pathologically. In addition to taking those prescription medications we talked about, the subject also adopted and strictly adhered to several diets. First, they tried the popular low FODMAP diet. They also tried the specific carbohydrate diet. You can Google those if you don't know what they are. But none of those put them into remission. But at the age of 23, still with the aim of finding a diet that would take care of these gastrointestinal symptoms, they decided to try a keto diet on their own. 75 to 80% of his calories came from fat, which was right around 300 grams of fat a day. 15 to 20% came from protein, that's about 130 grams a day, and then about 5% derived from carbohydrate, which was about 30 grams a day. So let me do the math real quick. So 300 grams of fat would be 2,700 calories. 130 grams of protein would add an additional 520, and then 30 grams of carbohydrate would be another 120. So he was eating a pretty good amount of calorie, but they said he was active and healthy, probably athletic. He was getting about 3,500 to 4,000 calories a day eating this way. His self-reported major fat, protein, and carb sources included extra virgin olive oil and avocados, seafood, and low-carb, high-fiber vegetables. Within 1 week of going on this Mediterranean-styled keto, his gastrointestinal symptoms improved, and his fecal matter calprotectin dropped from 123 to 19, which is within the normal range of less than 50. As of the time of this case study, 8 months later, the subject has not had any new flare-ups. His compliance has been monitored by looking at his beta-hydroxybutyrate levels, which regularly come in between 1.0 and 3.0. That is a very strong nutritional ketosis. His calprotectin, remeasured on 3 separate occasions, has remained normal, despite the fact that he's discontinued all of his medications now. So look how powerful keto was. More powerful in treating this inflammatory disease than the most powerful medications that modern medicine could throw at it. Which begs the question, if a patient feels that good doing something that is non-pharmaceutical, why don't doctors go straight to the non-pharmaceutical thing first? Because here this guy suffered years, 2-3 years there, trying to figure out what I could do. His doctor lets him down by putting these Band-Aids on a gaping wound. And I know a lot of you guys can express the same frustrations when you've gone to see your doctor about things. I get it. People expect their doctors to be this great purveyor of all things health, but can I give you a newsflash? Doctors are drug peddlers. Can I just say it that bluntly? I just did, but doctors are drug peddlers. They have been trained to look at you physically, figure out what's going on physiologically with you, and then looking for a solution that is pharmacological. That is what doctors do. People have this high and mighty view of the medical profession and thinking, oh, they're all about whatever it takes to make you healthy. And I disagree. I think they're not bad people. They're not trying to purposely drug people up, but that's what they've been trained in. And the fact that there's very little nutritional health information taught to doctors in medical school, this is why fields of study such as naturopaths, such as nutrition-minded chiropractors, and such as functional medicine practitioners, these are the guys and gals that are really trying to help people, because they're not just putting a pharmacological Band-Aid on a problem. They're actually trying to look for the root causes of what's going on. And thankfully, this particular doctor looking at this patient dealing with this inflammatory disease recognizes that, yeah, you can heal with diet. Who knew? Well, we knew, but most doctors do not. So given the high-fat nature of this diet, his serum lipids were closely followed from the beginning. 1 week before starting the diet, a sub-fractionated lipid panel was drawn and then repeated 7 months later. Several alarming changes in conventional lipid parameters. In other words, alarming only to that traditional doctor looking at it from the perspective of the traditional way of looking at things. Remember those cholesterol guidelines we talked about earlier? It's alarming only within that context. They're going to explain why it's not alarming at all here in a minute. His total cholesterol went from 160, which was a little bit on the low side. Look what happened 7 months later after going keto. 160 to 450. Now, anybody that goes to a doctor and gets a 450 total cholesterol, your doctor's going to probably have a heart attack himself, because they think cholesterol is this great enemy in the health. We'll come back to that in a minute. His LDL went from 95 to 321. Okay. And his LDLP, which is the particles, increased from 1143 to 2259. That's on the NMR lipoprofile test. And LDL particle number, not the size, but the number, can increase like that. I've seen LDL P be as high as 3,000 in me. I've had LDL C, not quite 321. I think the highest I got was 290. And then total cholesterol, the highest I've ever seen is 383, I believe it was. Yeah. So you can get high cholesterol. The problem is, and I'm not sure if he's getting into this here in a minute. The problem is when you start running these cholesterol panels on ketogenic dieters who have very low triglycerides and higher levels of HDL, when you eat keto, you almost invariably have an incredible triglyceride to HDL ratio. So triglycerides generally go under 100 and sometimes well under 100. HDL generally goes over 50 and sometimes well over 50, and especially you women, I'm a little jealous of women because you guys have an especially easy time of getting your HDL cholesterol to go up. A guy can top out at around 75 or 80 at the most. Women easily can hit 100, 110. I've seen it again and again and again, and women just have an easier time getting HDL to go up. So when you have higher HDL and lower triglycerides, on the standard lipid panel, there's one number that they only calculate it. They don't directly measure it. Did you know this? I talked about this. I wrote a book about cholesterol called Cholesterol Clarity, What the HDL is Wrong with My Numbers. And in there, we talked about this, that LDL-C is a highly unreliable number for a keto dieter because it's going to be miscalculated. That LDL-C is routinely miscalculated because it's based on a crappy garbage eating person, or it's based on someone with higher triglycerides, which means they're eating a lot more carbs, and lower HDL, which they're eating a lot less fat. But if you eat a high fat, low carb diet, you're going to get those numbers in a healthy range with triglycerides and HDL. The calculation of the LDL is going to be way, way off. But what do? They always point the finger of blame at LDL-C. Somebody tell me how a calculated number, just guesstimate, we'll just throw it out there, some random number. How do we predicate medication or not medication on a random number on your cholesterol profile? And here's the big thing. When it's random like that, because a keto dieter has low triglycerides and higher HDL, it tends to be random higher. In other words, the calculation is miscalculated on the high end. So what does that do? Not only does it give you a high LDL-C, it then adds that LDL-C number, which is flawed, to the total cholesterol number. So that's what happened to this patient here. They got the LDL-C to go from 95 to 321. Well, no wonder their total cholesterol went from 160 to 450. Crazy. You also saw an increase in the total cholesterol because something good happened on the cholesterol panel, and that's the HDL-C went up from 48 to 109. Now, this is a male. He got his HDL cholesterol to go to 109. I'm extremely jealous because that's really stout. Since total cholesterol, HDL-C, and LDL-C are the cholesterol parameters reported on a standard lipid panel, these are the ones that would be used typically in a subject's care. So they're trying to make the point here. This is why it's insufficient to be using a standard lipid panel when you're looking at a keto dieter, because it gives you an incomplete picture. If we're going to look at anything on a standard lipid panel, it would have to be triglycerides. That would be the big one. If it's under 100, wow, good job. If it's under 70, oh my gosh, optimal. HDL, the same thing. That would be the other one on the standard lipid panel. Is it over 50? Great. Over 70? Outstanding. And yet, what do doctors focus on? LDL-C, remember that calculated, estimated number that is miscalculated when you eat keto? And by extension of that, your total cholesterol. And yet doctors have a hard time wrapping their heads around why those two numbers aren't relevant and why they put irrelevance on the two most relevant on the entire standard lipid panel, and that's the triglycerides and the HDL. It's almost as if they said, you know what, whatever the truth is, let's do exactly the opposite and see if we can mess with these people. And that's exactly what they've done. And look at how they've used it to manipulate patients to get on medications they don't even need. High cholesterol is not a disease. Cholesterol is not an enemy in your health. We've been doing some stories lately here on Jimmy Rants about the people getting COVID-19. The first thing that happens is their cholesterol significantly gets eaten up. Well, if you don't have any cholesterol because you got low cholesterol because you took a statin medication, you in trouble. Because the goodness that cholesterol serves in your body is to help with inflammation. And my theory is the reason this guy ended up having much, much higher levels of cholesterol to the tune of 450, that cholesterol is going to try to lower that inflammation in his body. He's got this ulcerative colitis, major inflammation going on. The cholesterol is what's saving him. That cholesterol is the firefighter going to the scene of the fire, which is this disease he has, trying to put out the inflammation. So why are we trying to lower it? I think it's a very good thing that his cholesterol went to 450. It is. All right, let's continue. According to the modifiable risk factor scoring criteria, similar to those derived from the Framingham study, but established for individuals 15 to 34, which is what this case study age group is, these changes ostensibly represent a 4-fold increase in their risk of atherosclerosis. Remember, looking at it from a traditional standpoint, not an actual 4-fold increase. That's what they believe it does. In this subject, a full fractionated panel was pursued and additionally included a size breakdown of the LDL and HDL lipoprotein particles, the LDL and HDL particle counts, ApoB mass, oxidized LDL, lipoprotein little a, and then PLA2 activity. That's a lot of kind of gobbledygook that you may not want to know about, but basically in that, and there's the graph if you want to look at it, but it's a little bit convoluted to see on camera there, but I wanted to show you that they do have the statistics. And on there, it shows a very different picture than what a standard lipid panel would show. The lipid subfractation, the subject's baseline lipids prior to keto were shown on the graph. His 7-month follow-up was on the left, and I kind of went over what those numbers were before and after. Of note, at the time of the 7-month follow-up, he also got what's called a coronary artery calcium scan, which was performed as a functional assay of plaque formation. So I've told you guys about this CT heart scan. So basically you go into a CAT machine and it will do a CT scan of your chest. And when it looks in there, it's looking for what's called calcified plaque. And if you have heart disease developing, calcified plaque would show up there. And so this guy ate an extremely high fat, very low carbohydrate diet, saw his cholesterol sky high. Look what happened to this coronary artery calcium, which anybody can have run, by the way. Just ask your doctor for the heart scan. They'll send you to this place to get the CT, and you're looking for a score as low as possible. 0 is perfect. I've done 2 of those in the last decade. Both of them came back 0 despite eating about the same amount of fat as this guy, 70 to 80% fat. When he had it ran, no significant findings, and his heart scan score was a big fat 0. In other words, no calcified atherogenic plaque. So do you see the disparity between just looking at that standard lipid panel, which is what most medical doctors would do, and then the actuality of what's going on in the patient? They're not unhealthy. He is healthier by all intents and measures. His inflammation's coming down. Yes, he has higher cholesterol, but his inflammation has come down. His HDL cholesterol has gone up, which is good. He's seeing good thing. And then the heart scan comes back a big fat 0. Are you seeing why a standard lipid panel isn't really telling you a whole lot? And that it's not a big deal if you have higher cholesterol on that test within the context of other numbers? So a standard lipid panel would have revealed that in this subject, a keto diet increased total and LDL cholesterol, shifting both parameters from optimal to more than twice the threshold for the high risk category. Even on the subfractionation, the visuals of the report itself indicated cause for clinical concern, an overwhelming shift in the parameters from normal to the more alarming yellow and red. Therefore, it is likely that were this subject only analyzed by their standard lipid panel, or the results of the subfractionation were not looked at holistically and critically, the clinical recommendation would have been that the subject end his keto diet, which was the presumptive agent of his colitis remission. This is the problem with modern medicine. We look at numbers as the be-all, end-all, when they should be looking at the patient as the be-all, end-all. Whatever protocol that a patient is using that's putting their disease into remission, how can you then say that some other marker on a blood test is going to show great disease when they're showing great health? This is what's been so frustrating to me. And we see it across the board. Doctors are very narrowly focused on various health markers, cholesterol being a big one. And it's to the dismay of every other thing that's going on good in the patient. It's kind of like my doctor when I lost 180 pounds on the Atkins diet, and the first thing he wanted to know when I told him I did Atkins is, what's your cholesterol? I'm like, why the hell do you care? Because I, for all intents and purposes, am far healthier than I've ever been in my life. And the first thing you want to know is, what's my cholesterol? Crazy, right? Okay, so after that, they would have said in the keto diet. Furthermore, this subject would have been prescribed a statin medication at 24 years old, given the mixed evidence of the use of statins for primary prevention. In other words, he didn't have a heart attack or heart disease or anything. It was to prevent that. Statin medications were never intended to be a preventative measure for cardiovascular disease. They only have tested them in people who have had a previous cardiovascular event. And yet, how many people go on these medications willy-nilly because their doctor tells them to for the purposes of prevention? They've never been studied as a preventative measure. And that's how they're being prescribed, though. The possibility that long-term statin use in low-risk individuals can contribute to atherosclerosis. So it is true. When you take a statin, and it's in chapter 5 of my book, Cholesterol Clarity, statins raise your risk of diabetes, they raise your risk of cancer, and they raise your risk, ironically, of all ironies, heart disease. Isn't that disgusting? And yet, this is the thing they're pushing on people, to lower your cholesterol because that's so unhealthy. Why? Prove to me that high cholesterol is a disease. Prove to me that high cholesterol is harming me in some way, when very clearly within the context of a ketogenic eater, it is not. Where's the evidence? Show me the evidence. What follows is a more nuanced analysis and discussion of the most relevant changes in the lipid panel, which we suggest do not confer as large of an increase in the risk as a cursory analysis of certain isolated measures and the report's color scheme otherwise imply. An argument could even be made that these changes represent an improvement. So what is perceived by mainstream medicine as detrimental, some of these things could be good, like your HDL going up and it adds to your total cholesterol. Newsflash, higher HDL is a good thing, but then they throw that in with total cholesterol. How does that help you to tell you that your high cholesterol, total cholesterol is your problem, but a lot of that is your HDL, which is good? Do you see how kind of convoluted this whole talk is? How have they gotten away with this for so long is what I want to know. All right, so I don't want to belabor the point because I think you're getting the point of this case study, that it's incomplete that we only look at a standard lipid panel. And when you're a ketogenic dieter, yes, your lipids can change. And some of us, they estimate about 25%, and I'm one of them, 25% of the people who eat keto get an abnormal response in their LDL cholesterol. But almost invariably, all those people who get this abnormal LDL response have mostly the large, fluffy pattern A and the less atherogenic pattern B LDL particles. And you tend to have lower triglycerides, you tend to have higher HDL cholesterol, and that lipoprotein little a, by the way, it can also go up. But from the people that I interviewed for Cholesterol Clarity, some of the cardiologists, they said, if you were in a tribe and you had high lipoprotein little a, you would be the one that would survive the longest. Everybody else would die off. But because you have this longevity marker, you'd be able to fast for many hours. That might be why I fast well, is because my lipoprotein little a tends to be on the elevated side. Now, when I do extended fasting, and I've run the test, you guys, I could start with lipoprotein little a of like 420 before fast, and then like 14 days later, I've done some long fasts. 14 days later, test it again, it'll be down to 160. So indirectly, it was actually keeping me fasting longer and with less pain. Did you know that? It's kind of interesting stuff here. All right, so let's see if there's anything else of consequence. But isn't this fascinating that we've got this case study out of Russia? And again, this was published in the journal Frontiers in Medicine, if you want to go look it up, last month, April 2020. But yeah, they go into a deep dive into all these other numbers and what they mean, and oxidized LDL, lipoprotein little a. Let's look at the summary. We reported on a subject who adopted keto for ulcerative colitis, successfully put his condition into remission, was also associated with an adverse change in his serum lipid profile. A deeper analysis reveals many of the changes were actually very positive. Rather than recommending the subject abandon the keto diet that has been successful in treating his disease, we recommend a slight nutritional adaptation to see if it optimizes his lipid profile and health. So the significance of this report in this case study is threefold. Although clinical anecdotes reveal ketogenic diets can improve symptoms of patients struggling with various inflammatory diseases, there is little published data on the topic. This report documents an instance that a keto diet has helped with one of these inflammatory diseases. We also provide data that strongly suggests, at least in the case of keto dieters, that a standard lipid panel may not be sufficient, and that analyses of lipid subfractionation, that's a hard word to say, subfractionations. Is it Monday? Yes, it's Monday. So the NMR lipoprofile would give you those subfractionations, may be required in order to find the optimal clinical recommendations. If you go see a functional medicine practitioner, they will run an NMR lipoprofile test. And then this case also represents an example of the positive trend in medicine away from a formulaic care, which is looking at things like LDL-C and total cholesterol only, and more towards holistic, personalized, and integrative care. Amazing, right? This was an incredible case study. Let me get you the author's name. Victoria Bunik, B-U-N-I-K is her name. And she's from Lomonosov Moscow State University in Russia. And this was published in the April 15th, 2020 edition of Frontiers in Medicine. But guys, this cholesterol thing, I wrote that Cholesterol Clarity book in 2012 was when I wrote it. It came out in 2013. It is still relevant now more than ever before, because for some reason or another, people still worry about the cholesterol. And I'm shocked how many people in the keto space worry about their cholesterol. If you want to look at anything on your standard lipid panel, triglycerides and HDL, those are going to be the telltale sign. If you have triglycerides definitely under 100 and you have HDL definitely over 50, you can almost bet that your LDL particle size is going to be the pattern A. Now, you want to double check it. There are tests, the NMR lipoprofile test. There's another one called the VAP test, but definitely there's plenty of them available, and any doctor can run this. So you can just ask for the particle size test. If they refuse, you can order them yourself online here in America. Anylabtestnow.com and then privatemdlabs.com. Also, you can run these yourself. You go down to your local LabCorp, they draw the blood, and within a few days you get an email directly to your email that gives you your results. So, all right, I want to see what you guys have to say about this idea that higher cholesterol for a keto dieter probably isn't as big a deal as we think it is. So we're going to come here first to my Instagram page, then we'll pop over to Facebook, and if we have time, we will hit YouTube Live. Welcome in, welcome in. JimmyRants.com is the website. Good morning, good morning. Thanks for being here today. Welcome Home Farm says, it's hard to understand why the medical community is stuck on the one factor regardless of the other factors in our physiology. They are, because we have a drug that will fix that one factor. Statin medications, let's give them their due. They do lower cholesterol. Do you know how they lower cholesterol, by the way? Statins lower all of the good, large, fluffy LDL particles. And so you kind of eliminate the good part of your LDL. So it looks on a standard lipid panel like it's a very good thing, when it actually makes you a little more of a sitting duck. No, thank you. Mimi says it's not as big a deal as dragging around that extra 180 pounds. Exactly. Blazer Mama, my docs are thrilled with me being on keto. My lipid profiles are perfect. A1C is perfect, and losing weight. Yeah, not everybody gets this abnormal reaction. Like I said, it's about 25% of people who eat a ketogenic diet get this adverse reaction in their standard lipid panel. But kudos on your A1C being great, losing weight, your cholesterol looking good. I wish they would put more emphasis on things like insulin and A1C, but they don't. They really don't. Keto Gilio says, I try not to worry about it, but not gonna lie, I kind of cringe when I hear how high it has gotten. I just try to slap those thoughts out of my head. Yeah, I get it, because we've been indoctrinated for so long to think that it means something, but it really, really doesn't. Numbers are easier to treat than individual people. Oh, we could go on all that all day long. Like I almost used to hate it going to my doctor. He very rarely looked at me. He looked at my blood work and the results, never hardly ever looked up at me. It's one reason I fired him, because he wouldn't run fasting insulin, and I didn't feel like he was really treating me, the patient. Now, part of the problem was I was a whole lot more educated patient than most of his patients. I guess he just expected me to roll over and do what he wanted me to do, and quite frankly, he was not the boss in that relationship. I was. You are too, by the way. If you go to your doctor and you think that doctor is the be-all, end-all boss of all things about your health, consultant in your health. You make the final decision. Bonnie says, my calcium score was great, lipids great, lost 40 pounds, blood pressure great. Reason for meds, doctor said after argument, because I do keto. Oh, wow, the doctor wanted to put you on the meds simply because you do keto. Again, for all the reasons we talked about here today. Beth says, I agree, they are trained to peddle drugs. Even more, they're incentivized to write them. Yep. Sadly, that is true. True. All right, thank you, Instagram. Let me pop over here to my Facebook page, see what you guys have to say, and then we'll pop over to YouTube next. Hey guys, what's going on? Let's see what you guys have to say about this particular story here today. Dustin says, my primary care physician watches my cholesterol numbers. She knows I'm keto. Expects my numbers to be up a bit, but she's not worried. Also had an issue with blood pressure, but only with the auto machines. Though she takes my BP with the manual cuff and it's normal, so she leaves me alone. Well, good. Keep up the good work. That's awesome. Tammy says my LDL is 305 and my coronary artery calcium score came back 0, so it's all good. It is all good. See, that's the disparity there, Tammy, that any doctor that comes back and you need to be on a statin drug because you've got a high, in their mind, high total cholesterol. The first thing you ask for is an NMR lipoprofile test to get the particle size test done. And then the second thing you ask for is a coronary artery calcium scan, the CT heart scan. If they refuse to do those things, then you fire that doctor, okay? Because they should be able to, if they're going to push a drug on you before you take this dangerous medication, you need to have all the facts, and you don't have all the facts until you run these other tests. Good to have you back. Stay strong. Thank you, McKay. I plan on it. Appreciate all your support. All right, let's pop over here to my YouTubers. Hey, guys. Live chat. See what you have to say. Nurse Feel Good. My cholesterol has always been great. Gets even better when I started keto. I have lost a huge amount of weight. That's awesome. Karen asks how I'm doing. I'm doing good. Thank you. Harp C says an interesting rant. Well, we try to make them all interesting, but I'm glad you like this one. Spiral says, I finally caught a live stream. I want to talk to my mom about the false beliefs that her doctors have shared about cholesterol. I'm trying to convince her to go low carb for type 2 diabetes. Yeah, if you're type 2 diabetic, it's tailor-made for you to go low carb keto. In fact, the lady that now is the president of the American Diabetes Association, we've been trying to help that organization for years get with the bandwagon and understand type 2 diabetics need a low-carb ketogenic diet. Well, the president of the ADA is now a low-carber. So this is why some of their guidelines have already started to change, allowing for low-carb to be used in the controlling of diabetes. So that's good news. All right, guys, so that's an interesting story here today. Again, if you joined late, Frontiers in Medicine had a case study from a researcher out of Russia, Victoria Bunick, and she looked at a patient with ulcerative colitis, and she found that the standard lipid panel didn't really do much to tell her what was going on in her patient, and that it was insufficient because the patient was eating keto. And so if you're eating keto today and you've been told by a doctor that you have high cholesterol and that you must take a statin medication, you're going to get a heart attack. They throw every manipulative technique at you when you have high cholesterol. And I'm here to tell you that's a whole bunch of bunk. There is no evidence that shows high cholesterol leads to heart disease. High cholesterol gives you a heart attack. You know what gives you a heart attack and gives you heart disease is inflammation in the coronary arteries. How do you get inflamed in your coronary arteries? And I wrote about this in Cholesterol Clarity. 2 primary things increase inflammation in the body in your diet that increase it faster than anything that really puts you at great risk. It's carbohydrate and it's vegetable oils. So if you're still eating lots of especially refined carbohydrates, it's time to eliminate those and greatly reduce even the whole food versions of them. And then the second thing, vegetable oils. If you're still eating conventional mayonnaise and salad dressings, or cooking in corn oil or soybean oil, or you're having nuts roasted in those things, cottonseed oil, it's time to eliminate those things. You want to keep inflammation low. You don't really care about your total cholesterol. That's it for this episode of Jimmy Rants. JimmyRants.com is the website. As always, you need to engage live over here on Instagram. I'm at Livin' Low Carb Man, LIVIN LOWCARBMAN. We also simulcast jointly on my Facebook page as well as on YouTube Live. So thank you all for being here today on Jimmy Rants. We go Monday through Friday, 11 a.m. Eastern time. Sometimes I throw in a 5 p.m. Eastern one during the week, and then sometimes on the weekend. Over this past weekend, I did one on Saturday, and then I took yesterday off. but always at 11 a.m. Eastern time, unless I'm not feeling it. But most of the time I do them at 11 a.m. Eastern time, Monday through Friday. So thanks for being here. If you missed the live, it does show on replay for up to 24 hours. After 24 hours, it does disappear. You'll need to pop on over to jimmyrants.com. That's where we house all the past episodes of this show. And then we also put them up on YouTube. Just type in a keyword Jimmy Rants and you will find the show. So guys, that's it for now. Thanks so much for joining us and we'll see you again soon. Bye. All right.